Good afternoon, everybody. Thank you for joining us. We're going to start momentarily. We're extremely excited for today's event. I'm going to introduce our speaker, Ms. Mary Mayhew, but Dr. Dean Littles will kick us off this morning with a welcome.
Well, good afternoon, everyone. I do extend a very warm welcome to our students, faculty, and staff who are with us in person, and to our alumni and others who are joining us via live stream. And that cliche, it feels like church because everybody's sort of pushed back, but that's okay. We do want some interaction as we go through the hour here. I'm delighted that our guest speaker, Mary Mayhew, President and CEO of the Florida Hospital Association, expressed an interest in speaking to our students, faculty, and staff, and that we can offer this presentation to our alumni and others throughout the state of Florida and beyond. Undoubtedly, Ms. Mayhew will share information and data important to us as we go about our daily lives, providing patient care, conducting research, and teaching our next generation of healthcare providers, all within the context of the medical business environment, which is constantly evolving. For those of you in practice, you know how important it is to not just know the art and science of medicine, but also the business construct that makes it possible. At the College of Medicine, we work closely with major hospitals throughout the state of Florida, as well as with hundreds of other providers, and even some outside of Florida. With our distributive model of medical education, we gain a holistic view of the challenges and opportunities that each of you face, and therefore what our graduates face as they progress in their careers. I look forward to hearing Ms. Mayhew's remarks and learning more about our current and future environment regarding workforce opportunities, payer models, legislative changes, and other topics, and I thank her for joining us today. On a personal note, I'd like to thank Ms. Mayhew for all the work she does with the Council of Florida Medical School Deans, beginning with her time as Secretary of the Agency for Healthcare Administration and continuing in her role with the Florida Hospital Association. I'd now like to invite Dr. Heather Flynn, Chair of our Department of Behavioral Sciences and Social Medicine, to introduce Ms. Mayhew. Dr. Flynn.
Thank you so much, Dean Littles. So I'm Heather Flynn, and it is just my pleasure to host, along with many student interest groups today, this session. Mary Mayhew reached out and expressed an interest in communicating with our future doctors, our medical students here at the College of Medicine, and I was just delighted because this is really meeting us at a critical point in our evolution here, not only at the College of Medicine, but at FSU. Many of you know that we are now building an entity known as FSU Health. This will really put FSU more into the healthcare space than we've ever been, and we are very excited that this really affords the opportunity for FSU to, with the College of Medicine at the lead, to build innovations in research, training the next generation in healthcare, as well as innovative healthcare delivery for the future, not the last 25 years, but the next 25 years of healthcare, which is why I'm so excited to have Ms. Mayhew at this particular time, as all of us as a community come together to envision what can we uniquely do here at FSU. Unlike some of our other partners or other universities, we have our students throughout the entire state, and you guys are the future of healthcare, so this is really, really important for us. I'm going to not spend too much time, but Ms. Mayhew has an incredible track record. We're very fortunate to have you with us. She is president and CEO of the Florida Hospital Association, FHA, which represents more than 200 hospitals and health systems throughout Florida. Florida's hospitals provide care for 11 million patients a year, provide jobs for more than 300,000 Floridians, and contribute $177 billion to the economy each year. Since joining FHA in 2020, Ms. Mayhew has advanced policies that strengthen the pipeline of healthcare workers in Florida, something that's near and dear to our heart, has coordinated response and recovery from natural disasters, might be another one coming, and successfully advocated for critical funding resources to support access to vital healthcare services for Florida's most vulnerable patients and families, something else near and dear to our heart. Prior to joining FHA, Ms. Mayhew served as Secretary of the Florida Agency for Healthcare Administration, AHCA, in the administration of Governor DeSantis. As Secretary, she played an instrumental role in the state's response to the COVID-19 pandemic. She also spearheaded several initiatives to support increased accountability for improved healthcare outcomes for more than 4 million Medicaid enrollees. And I've been privy to some of this and have seen how she's promoted integrated care coordination, which is a real growing emphasis here in Florida. Ms. Mayhew joined AHCA from the U.S. Department of Health and Human Services, where she served as Deputy Director and Administrator of the Center for Medicaid and CHIP Services, overseeing more than $375 billion Medicaid program. She was also served for more than 6 years as the Commissioner of the Maine Department of Health and Human Services, where she advanced comprehensive health homes, Medicaid accountable community organizations, integrated behavioral health homes, and efforts to improve access for substance use disorder and primary care. Again, very aligned with our goals and mission here. And she, promoting high quality behavioral health services remains a major priority for Mary. She has just a wealth of experience. Personally, I've heard you speak numerous times, and each time it's really, not only do I learn a lot, but she takes a very data-driven and actionable approach. So I always leave your presentations feeling optimistic about what we can do together as a state, as a nation. So I, without further delay, extremely delighted to welcome Ms. Mary Mayhew.
Thank you. Well, good afternoon.
Good afternoon.
And you are so far back. All right, I can project. Well, let me. First of all, when I die, on my tombstone, it will say, "The woman loved her PowerPoint slides." So let me first introduce Ryan Mahone and Justine Hicks on the FHA team. They are an integral part of our ability to come out and present and talk and shape context. What I want you to think about throughout my way too many PowerPoint slides is really common sense. Bottom line, are we making a difference in the lives of individuals we care for, who rely on a variety of different services and programs? Are we making a difference, and how do we know that? Okay, I'm going to come back to that over and over. How do we define success? Are we measuring what matters? And how do we get past the constant phrase of, but this is how we've always done it, right? How do we lead? So, where shall I point this? Is it on? Oh, let's try that. All right, so optimism. Sometimes I've been accused of my presentations being a little bit of a Debbie Downer. This is my son 30 years ago. We celebrated his 30th birthday a little more than a week ago. He was born very prematurely, 2 pounds, 9 ounces, 12 inches long. Now I just realized, Ryan, I probably should have put a picture of him now at 30. But the bottom line is, obviously, I was incredibly fortunate to have the care that I did 30 years ago. But you know, I also have the opportunity now to go through NICU units around the state. The world has changed dramatically. There were no private NICU areas. I was there with 20 other moms and babies crying my eyes out, not knowing what was going to happen. We have made such a huge difference now for moms with premature infants. And we've got to remember that, right? The world continues to change. One of the other things I often say, my mother was a nurse's aide. And when I was little, much like the workforce challenges we have today, if she said, Mary's sick, I need to stay home, they'd say, no, Sue, bring her to the hospital. And they'd put me in the nurse's lounge. And guess what was going on in the nurse's lounge? They were all smoking. So I had a cold and I'm inhaling secondhand smoke like nobody's business. But again, the world has changed. So when we think things are not changing, do know progress is being made, and we got to keep pushing. So Ryan, hopefully our technology is going to work. I don't know. I see it's so good that you're right there, Ryan. This is a video.
Recommend Clubhouse to.
I want you to just listen.
Struggling, not only with mental illness, with, just a saddened heart or a substance abuse issue or something. Because Clubhouse has just been there for me, and something about the place won't let me leave it alone. And I am just so happy to have that as part of my life today.
It's all about human beings. We can make healthcare so incredibly complicated. We've got more regulations on so many different fronts, and we often lose sight of, at the end of the day, what matters. And I'm going to talk about mental health a little bit more in the presentation. But that was Jessica. She spoke in front of 400 people along with several of her peers at my annual meeting last year. And I brought them up on stage and did a bit of a fireside chat with them to talk about the mental health system and what has mattered in their lives. And again, one of the things that I want you to keep in mind, we haven't invested in a lot of areas of healthcare that are far less expensive, but have incredible results. Jessica was referring to what is known as a Clubhouse model. It's for individuals with serious and persistent mental illness. Think of someone 28 years old with schizophrenia. This is where they can go interact with people who are having similar life experiences. It also has a vocational component to help individuals to find work, to be supported. Life-changing, the Clubhouse model. Incredibly inexpensive. Our system of payment has not necessarily rewarded for those lower cost interventions. We respond to the acuity, to the crisis. Now, the point of this next slide is a lot going on in terms of other companies trying to get into healthcare. I've got so much to go through, but I want to share a little bit. So Walmart, many of you may not be aware, about 20 years ago, they said, we're going to do clinics. And they got into the world of doing clinics. And then they stopped. Well, just a few years ago, they decided to get back in it. In fact, when I was secretary, I went to Dallas, Georgia, the site of their first clinic. Beautiful primary care clinic. They had community health workers that were going out to the local community center. Amazing model. But I, of course, said to the gentleman that was giving me the tour from their headquarters, what's going to make a difference this time? The answer wasn't all that complicated. He just said, well, we've got really good data analytics. Well, you can see from the headlines, they just closed. They had 22 sites they were opening or had opened in Florida. And the bottom line for them, we couldn't make money. And you're going to hear that theme, right? Our ends meeting. Are we supporting financially the goals, the objectives, the mission of delivering high quality, comprehensive health care efficiently and effectively with the best possible outcomes? Right care, right time, right setting, best possible outcomes. Closer to home, Steward Healthcare. How many of you are familiar with Steward? National Health System just declared bankruptcy. Number of facilities in Massachusetts, but quite a few here in Southeast Florida. Again, we don't know all of the internal decisions, management decisions they made, but I'm going to show you what Steward and so many other hospitals have been contending with. Some of it cyclical, but now add in, of course, as we experienced, an unprecedented pandemic. Drug shortages. There are, a hospital health system, any healthcare provider starts off the year with a budget and a plan. And then there are all these unforeseen situations that in order to keep your doors open, you've got to be at the ready to respond to. So drug shortages, things that could not necessarily have been predicted. But how about this? Cybersecurity. Healthcare is the #1 target for cyber attacks. This happened against the country's largest health insurance company, United Healthcare. So, because when I was doing a lot of media interviews, the reporters would say, how are you going to stop this kind of attack from happening to hospitals? I said, this was the largest health insurance company in the country. And it was a successful cyber attack on their subsidiary. The impact was massive, even though when this first occurred nationally, the communications with the United States Department of Health and Human Services by United, they were downplaying it. They said a couple of things, and this is where you always have to be engaged around, is the narrative accurately depicting what's occurring here? They made it sound like, this is just back office operations. And hospitals can just convert to manually submitting their claims. So hospitals over many, many years, of course, have automated their claim submission. This is, of course, very complicated. All the edits that have to be done based upon the various policies of health insurance companies. So we have what's called claims clearinghouses. And that's what was attacked by a Russian-backed cyber criminal ransomware attack on United, their subsidiary, Change Healthcare. Now imagine if you are a small, medium-sized healthcare provider. I'm talking about hospitals, but this was also affecting physician practices. You're small, you're medium. You don't have a ton of cash reserve. If you can't submit claims for care you've provided, it affects your ability to meet payroll, to pay for the very individuals who are delivering the care. This is only going to get worse. Here's what happened more recently in August. Again, I'm not sure that the media fully understood. This should have been everywhere. We should have been papering the state on this. This was an attack, again, Russian-backed, Russian-based, however we want to describe it, cyber criminal, attacking Florida's blood supply, OneBlood. In fact, the FBI had been warned. There had been an attack on the blood supply in England. FBI was warned an attack is going to happen on the blood supply in the United States. Where did it happen? It happened here in Florida. What we all learned through this, have you ever heard the expression single point of failure? Where you've got such incredible dependency on one individual or one entity. In this case, OneBlood supplies more than 80% of Florida's blood to Florida's hospitals, more than 80%. The attack happens on a Sunday night. Monday morning, hospitals are expecting delivery of blood. Guess what happens? No blood's arriving. The biggest concern were platelets. Platelets are used in organ transplants, cancer treatment, open heart surgery. There are a number of high-risk platelet-dependent procedures, surgeries, and services. Again, OneBlood, the entity that was attacked, didn't tell anyone until Wednesday, or at least not publicly, that it was a cyber attack. But they were the ones communicating at the federal level. Again, here's what the United States Department of Health and Human Services heard, and our state officials. This is no different than a hospital preparing for a hurricane. Not true. Secondly, this is just going to affect electives. Did you hear electives before in my list of organ transplants, open heart surgery, cancer treatment? Not electives. So we had to change the narrative urgently. So platelets have a shelf life of 4 to 5 days. All of a sudden, if hospitals were receiving anything, they were getting platelets that expired in 12 hours, in 24 hours. Hard to plan your inventory when that's happening. Again, we had to quickly escalate and raise awareness at the state and federal level in order for them to understand the magnitude. Organ transplant surgeries were being rescheduled. A lot learned from this. At one point during that week of OneBlood being completely shut down, more than 80% of the platelets for the state of Florida were coming in from out of state. We have a lot of vulnerabilities in this country's blood supply. Had anything been occurring in some other part of the country that required urgent delivery of platelets, the situation here in Florida would have been drastically different. So all of this, and again, I'll keep coming back to a variety of aspects of the system, but for now, with regard to hospitals, another friction, another pressure point, significant one, has been our workforce, right? You can't deliver care if you don't have an adequate supply of all your healthcare professionals, nurses, surgical technicians, physicians. You've got to have the workforce that's ready to meet the demand, respond across the continuum. Well, what happened during the pandemic? First of all, we had a lot of nurses in particular that left to become known as travel nurses. Remember now, at the beginning of the pandemic, the surges were happening at different times in different parts of the country. So nurses needed to go to Washington State. They needed to go to New York and California. And they were leaving because the pay was incredibly attractive, which meant that for hospitals here in Florida, all of a sudden now, we're dealing with much larger vacancy rates, turnover rates. And then, of course, the surges started happening largely at the same time around the country, which then created a significant challenge with our workforce. The bottom line with this slide, and if I had showed you this a year ago, you would have seen workforce costs for hospitals having increased 45%. It's hard to even get your head around a 45% increase in your workforce costs. And that's because hospitals were not only having to pay these much higher rates for temporary staffing, temporary nurses, but they were also dramatically increasing their base wages to nurses, to other professionals to try to attract them back or retain them. In this slide, you'll see things are getting a little bit better, but still, 70% of a hospital's budget has increased 35%. Their cash on hand declined. So who pays for most of the care delivered at hospitals and other providers? Who pays? Insurance companies. We've privatized Medicare. I'll show you a little bit more on that. We've privatized Medicaid. And if you have commercial health insurance, right, insurance companies. They're not going in during contract negotiations and saying, how can we increase our contract with you by 35%? They're coming in and maybe giving single digits, 1-2% increases. The gap increasing between the cost of delivering the care and the reimbursements. At a time when we're also looking at charity care costs for people who don't have insurance as they come to the emergency department, we're going to screen and treat them, along with other aspects of the system where we're supporting individuals who have no insurance, so charity care increasing. And then more recently, the federal government, and I want you to be very clear about my remarks on this. There's nothing wrong with some of these requirements, and particularly this new requirement, which is hospitals now must screen everyone for housing instability, homelessness, transportation barriers, food insecurity, and public safety concerns. There will next be, undoubtedly, as that data is collected nationally, now what are you doing about it? Now there are all kinds of efforts underway around the state where hospitals are partnering with local coalitions who are charged with, have responsibility to address a number of these social determinants. But you know, for decades we've been talking about how critically important it is to recognize social determinants when we're also trying to address somebody's health. If you have diabetes and you're homeless, awfully difficult to manage your diabetes, right? We have to understand this. But again, large insurance companies sitting across the table from us, not coming anywhere close to the increased cost of delivering care, the mission is expanding. And for hospitals around the state, Florida's a bit of an aberration. In other parts of the country, the tiny little state that I originally came from in Maine, hospitals employed over 85% of all the primary care physicians. Why? because those primary care physicians came to the hospitals and said, I'm going to have to close up shop because I am hemorrhaging red ink. Medicare and Medicaid are failing to cover my costs. If you don't employ me by my practice, we're going to have to leave town. So hospitals, in order to preserve access, started more in rural parts of the country, expanding rapidly to all aspects throughout a state, rural, urban, in order to preserve fundamental access. So pediatricians, we'll talk more about this as well, but they generally have a lot of Medicaid. So if Medicaid doesn't cover the cost, you're going to have a hard time making ends meet. So this is making that point. So for hospitals, not surprisingly, as you get older, you require more health care. So their Medicare is a larger percentage of our admissions. When you combine Medicare and Medicaid, they account for 2/3 of all hospital admissions. But do you see that next data point? They only account for 40% of the payments. So if Medicare and Medicaid, through their health insurance companies, aren't reimbursing for the cost of care, you have to make it up on your commercial health insurers. Cost shifting. This bears repeating. I've got another slide on this, but Medicaid, which pays for 46% of all births in Florida, pretty much true around the country. 46% of all the births in Florida paid for by Medicaid, largely driven by the state, even though we benefit from federal Medicaid dollars, historically has reimbursed hospitals until this most recent legislative session 35 cents on the dollar of cost. 35 cents. So I'm often asked, why does the MRI at that hospital cost more than the freestanding imaging center? Well, because the freestanding imaging center isn't delivering babies, right? So they can have a much lower charge, but if you're trying to cost shift and subsidize and preserve access to moms and babies so they don't have to travel great distances, you've got to find how you change your pricing elsewhere to make ends meet. So one of the things that's not understood, so it comes down to how are the people in Florida covered? What insurance do they have? So one of the things that's not as understood about the Affordable Care Act, a lot of politics about the Affordable Care Act, which sometimes shuts down meaningful discussions and education because it becomes so polarizing. Medicaid expansion being one of the bigger, more contentious, polarizing conversations. But this is the number of people in Florida. We lead the country in the number of individuals in Florida who are getting their coverage through the marketplace, the federal marketplace. This was created, this did not exist before the Affordable Care Act. The bottom line here is if you're getting covered through and if depending on your income, and I'm going to explain where it doesn't apply as broadly in Florida, but depending on your income, you're getting subsidies and discounts to pay for the coverage. And for providers, you're getting commercial health insurance reimbursement rates, much higher than Medicaid and Medicare. In that previous slide, Medicaid on average pays 50 cents on the dollar of cost for all reimbursement. 50 cents on the dollar cost. You don't make that up in volume. Right? If you're getting reimbursed half of what it costs, the more you do doesn't help you bridge that gap. So very helpful. So here, our population in Florida is growing rapidly. At one point, we had over 1,000 people a day moving to our great state. Many of them, of course, are over the age of 65. And that percentage of the population is just going to continue to grow. And as I said before, as we get older, we use more healthcare. So the demand for healthcare in Florida is just skyrocketing. Here's what's important. It just can't be how we've delivered care over the last 10, 15 years. We have to reimagine how care can be delivered. This is but one example. During the pandemic, when we were trying to protect our frail elderly no one, should be in a hospital bed any longer than is necessary for their care because of the risk of exposure to other infection, right? During the pandemic, that was certainly a significant concern. So the federal government authorized what was then known as hospitals without walls. Today now, this program known as Hospital at Home. This is just one example of, we are doing things today, reimagining how care can be delivered because technology is changing so rapidly. We are now monitoring patients in their homes with technology we couldn't have imagined 10 years ago. What else is possible? I saw recently one of the tiniest MRI machines I've ever seen for pediatric patients. There are 5 in the world, one is in Jacksonville. The world is changing. How do we make sure that when we're making policy decisions in Tallahassee and in DC, that we're looking forward and not managing from a crisis perspective? I say that, some of you may not have had to experience this, but we've had an exodus of property and casualty insurers. If any of you have homeowners insurance, I did here in Tallahassee. We're not exactly a hurricane-prone area, although that may change, or has certainly changed. But nonetheless, in other parts of the state, property and casualty insurers have exited, some statewide, which affected my property and casualty insurance. The legislature came in, but they're reacting to the crisis. When you're reacting to the crisis, it's often too late. The damage is done. The plans have left the state. We cannot afford to do that in healthcare. We've done it in mental health, and we're trying to make up a lot of ground in mental health. We want to keep pace. 3rd largest state in the country. We should be leading on modern, sophisticated healthcare, state-of-the-art, world-class care. So the pipeline. Do we have enough nurses and physicians? A few years ago, we did a study to look at forecasting the shortage of nurses and physicians if we did nothing in the state to address it, given our population growth and the increasing demand for health care. So the first, of course, for nurses, a shortage of nearly 60,000 nurses by the year 2035 if the state didn't take action. For physicians, 18,000. Now, important to look out that many years because it takes time to prime the pump. Certainly true for physicians. The great news, data matters. Let's just start there. Data matters. We hired a firm. The legislature then responded. It galvanized action in the legislature. They created what's now known as the line and pipeline funds to provide more support to universities and colleges, to their nursing schools, to increase capacity, to train more nurses, to produce more licensed nurses at the end of the day to meet demand. The matching fund allows hospitals to partner with community colleges and universities to support that. I'll get back to what this state has been doing for graduate medical education. Here, great news. Again, because of the pandemic, we had significantly high vacancies and turnover rates. Hospitals have been, as one CEO described it to me, like a war room mentality. Every single day, what are we doing? How are we doing it? Are we improving, reducing our vacancy rates, reducing our turnover rates? Imagine, for vacancy rate, we had a 21% vacancy rate. We've now reduced that by over 62% in little more than 2 years. That's a lot of effort on looking at professional development, looking at the workplace environment, tuition reimbursement, scholarships, a host of initiatives because we're competing, by the way, with 8 to 5, Monday through Friday, healthcare opportunities in the community. Hospitals, of course, are 24/7, and if you get admitted to a hospital because of the scrutiny on inpatient admissions by insurance companies, you're really sick. So the acuity of our patients has increased. On the turnover, what's the workplace environment like? How do we improve the workplace environment? Again, a 45% reduction in our turnover rates, largely reflective of a host of efforts to look at how care is being delivered, in particular team-based models of care. Same is true for our allied health professionals. We're looking at the vacancy and turnover rates. So we're commissioning another study to look at the shortages for a number of our most concerning allied health professions. Think surgical technicians, imaging technicians. We're going to take the results of that, same thing. Go to the legislature, talk about expanding capacity, funding at our community colleges. I'm going to go through a number of these. So for hospitals, data is important to understand the different provider types. Of course, hospitals employ the vast majority of RNs, of nurses, not surprisingly. I won't get into a lot of this here, but I'm very concerned about the breadth of our continuum, especially in long-term care. What most individuals need as they get older, what they first need often is they struggle to get bathed, get fed, get dressed. If any of you have older relatives and your families are trying to support them in their homes, Medicare doesn't pay for that. Medicare, the insurance program for the elderly, does not pay for what's known as activities of daily living, getting bathed, getting fed, getting dressed. So families then scramble if they're not on Medicaid, and even if you are on Medicaid, that is a capped program, it's a budget cap. You can be on a wait list for Medicaid, so then what do? And if someone's condition deteriorates because they don't have that, where do they end up? In the hospital, in the emergency department, in much more expensive 24/7 facilities. Housing. There isn't a conversation around workforce that doesn't come back to, well, we can attract physicians to Miami, but if they can't afford to live there, if they can't afford to pay for housing, if we attract nurses to Naples, Florida, or Tampa, and they can't afford to live there. So hometown heroes established by the legislature to provide some initial financial support for housing. You are going to hear more and more and more about this. How do we connect the dots? A lot of hospitals investing more in housing developments around their campus so that people also aren't having to drive an hour to get to work. In Miami, that might mean 10 miles. Physician workforce. So we're constantly looking at our capacity and understanding where we have shortage areas. Closer to Tallahassee, over in Panama City, Pensacola, you can have great health insurance, commercial health insurance, be new to the area, and wait 8 months to get into a primary care physician office. Remember, right care, right time, right setting. Primary care is key. If people can't get into primary care because we haven't incentivized it, we don't have enough, they're going to end up relying on the emergency department, the most expensive point of entry to the healthcare system. And this just breaking down primary care physicians, as I said, by county, looking at how do we inform decisions to incentivize. And the legislature has done some great work around this. But here's where we're disadvantaged in Florida. Graduate medical education, largely funded by Medicare. Entirely a federal program. Medicare, entirely run by the Centers for Medicare and Medicaid Services, though it is privatized, largely. But the vast majority of graduate medical education is funded by Medicare. Well, Congress, in its infinite wisdom, back in the 1990s, was worried about how much money was being spent on graduate medical education by Congress, so they capped what states received based upon their population in 1997. Guess what has happened to Florida's population since the 1990s? It has exploded. So all I want you to see on there is what Massachusetts receives. Massachusetts has a population about 7 million. They're getting 55 residency slots funded per 100,000 by Medicare. What is Florida getting? We, of course, now are up to 23 million in our state. We're getting 19 slots per 100,000 funded for residency for graduate medical education. New York is getting what? 76 slots per 100,000. Now here's the problem with this. This is politics. It's not Democrats and Republicans. It depends on your state. But let me tell you, Senator Chuck Schumer is not going to say, how can I send our money to Florida? It's just not gonna work that unless Congress increases. Now we've been working with Florida's congressional delegation to figure out a way to remedy that formula. But it's redistributive unless they put more money into it. But here's what the state of Florida has been doing. They've been using Medicaid money to expand graduate medical education. We are now up over $560 million being spent out of the state's Medicaid program on graduate medical education. Remember Massachusetts? 55 slots per 100,000. Massachusetts isn't spending a dime of their Medicaid money on graduate medical education. Guess what that means? They can put that money toward reimbursing primary care physicians, pediatricians, dentists, mental health. Important to understand that disparity and the ramifications. The bottom line, of course, we know where people do their residency, they are more likely to stay and practice. If we don't have adequate residency slots, we can educate in our medical schools, but we will then export those individuals to states with residency slots. Here's another problem. We are an incredibly litigious state. If you don't know that, how many in the room may be from Southeast Florida, down in the Miami, Broward area? A few billboards will tell you, if you don't know who to call to file a lawsuit, just look up on the billboard. So we have a huge problem in our state with a litigious climate, and then you factor in medical malpractice. So our malpractice premiums have been increasing. We have OBGYNs in certain parts of the state who've literally gone bare. They cannot afford to purchase medical malpractice. But what do we normally talk about around healthcare? The affordability. And it's so easy in a lot of debates to just say, hospitals are expensive. Healthcare is expensive. It's a lot harder to tease apart to say, well, why? Why is it expensive? Some of it is, as I said, right, we're using a lot of preventable, high-cost spending in the emergency department, preventable. But here, it's not just the premiums. Hospitals are getting sued and they don't dare go to court, even if they know they could, or are optimistic they could win, because of what's now known as nuclear verdicts. There was a case down in St. Pete against Johns Hopkins All Children's. The settlement was over $200 million against the hospital. They're appealing. This gets into the child welfare arena. But nonetheless, if you are now afraid to go to court, you are going to get sued more often because they know you're just going to settle. So those payouts are exacerbating the affordability of healthcare, and on top of that, defensive medicine. If you think you're going to get sued, you're going to order more tests, more labs to avoid, or hopefully avoid, getting sued. I mentioned earlier about maternity care. Again, Medicaid pays for 46% of all births. They previously, until this last legislative session, reimbursed 35 cents on the dollar cost. We really worked hard to increase that because we have OBGYN deserts in Florida. Moms having to travel farther to give birth. So last session, historical increase finally in Medicaid reimbursement to hospitals. We're now up from 35 cents on the dollar of cost to 48 cents. That is improvement, that is progress. There's still a shortfall, there's still a gap. We'll still need to cost shift, but less. Medicaid increasing some of its support. Probably could say this a few thousand times. If you just remember one thing, but in this case, if you could just remember one thing from this presentation, when it comes to children in Florida and anything we want to do about their trajectory, their health, their mental health, whether they're ready for kindergarten, whether they're at reading level by grade, not grade 3, age 9, Medicaid is a huge factor. It is foundational. Medicaid and the Children's Health Insurance Program in Florida covers more than nearly 70% of all children. Nearly 70%. So what Medicaid pays for through the commercialized, the privatized program, what those commercial health insurers provide, pay for, insure in terms of network adequacy matters, especially 0 to 5, so foundational. And I can tell you, having been the secretary overseeing Medicaid here in Florida and in other states, we're not creating the kind of accountability we need to. Are we measuring what matters in outcomes? And I've said this, so we've got to look at these measures and understand the connectivity between Medicaid for children, pathways out of poverty, educational attainment. It's all connected. You guys gonna, 3 minutes, oh my. All right, I'm gonna go through a variety of these fairly quickly. So this one, hopefully, will also strike a chord. This was shared with me recently. So attracting physicians is critically important, so we know research matters, but we're also today experiencing children with cancer having to go out of state for care. Just look at the difference in the clinical trials. Imagine just the distance you have to travel to get access to these clinical trials, even though Florida has the second largest population of children. So that state-of-the-art, world-class care, how do we increase the commitment of resources around research here in Florida so our children, their families, do not have to travel out of state? I'm gonna go through. So Medicaid expansion, again, a lot of challenges in just having really good, meaningful conversations in education. So in Florida today, a mom with 2 babies who earns $3,600 a year, not a month, everybody thinks it's a mistake, a year, earns too much money to qualify for Medicaid in Florida. The Affordable Care Act, when it was passed, was based on mandatory Medicaid expansion. The United States Supreme Court struck that down. Based on the law and how it was written, it assumed that anybody under 100% of federal poverty would be covered by Medicaid. Supreme Court strikes that down. It did not provide any subsidies or assistance for anyone under 100% to get access through the federal marketplace. So that mom with 2 babies who earns more than $3,600 a year not only makes too much money from Medicaid, she does not get 1 dime of assistance on the federal marketplace. That is our coverage gap here in Florida. And again, if a mom's not getting in to care, she may not have the relationships locally that support that kind of engagement that we want as well for her children. Medicaid redeterminations, so the state and every state, so long as it was receiving federal public health assistance under the federal public health emergency, we were getting enhanced Medicaid payments throughout the pandemic. Those came to a screeching halt. And now every state must redetermine the Medicaid eligibility for all their enrollees. At our peak, we were at 5.7 million Floridians. Prior to the pandemic, we were about 3.8 million. We're now down to 4.3 million. Now, Department of Children and Families, do not blame them, but just keep in mind, these are databases. These are systems that have not been necessarily modernized. So imagine the eligibility system in Florida having to go through this kind of ordeal to redetermine eligibility. I am going to go through something very quickly. So Medicare, again, privatized Medicare Advantage. But here's what I want you to see. So there are insurance companies that dominate the landscape in Medicare, United and Humana. So we can talk about a lot of other insurance companies, but they dominate, okay? United and Humana. In Medicaid, known as Sunshine here, nationally Centene, they have over 40% of the enrollment in Medicaid. So when we want to look at accountability for in Medicaid's case, for the $36 billion a year being spent in Medicaid, are we making a difference in the lives of those who depend on Medicaid? What is Centene, Sunshine, doing to support those goals? Last year we had 250,000 patient days, remember affordability of healthcare, 250,000 patient days of patients stuck in hospital beds who we could not safely, timely, or appropriately discharge. because there wasn't the next level of care that would either be authorized or available. The vast majority needed to go to a skilled nursing facility, nursing home, and in large part, the Medicare Advantage plans were not authorizing. Now, so long as that patient is in our hospital, the same cost applies, but once that patient is there longer than the average length of stay that our payment is based on, we're not getting paid one additional dime. $500 million in preventable spend. So the affordability of healthcare. I'm gonna go through some of these very quickly. You guys will have all of these, but let me just, one other area that I want you to be focused on. So mental health, let me just leave you with this. Right care, right time, right setting. Mental health in this state and most states around the country was developed, driven in the community, in large part as a result of class action lawsuits that said, it is not okay to warehouse individuals, lock them up in large state mental institutions because they have mental illness. Those lawsuits are 20, 30, 40 years old. The problem is, while we responded to those lawsuits, we closed those facilities or reduced the size of them, the people didn't go away. And we also know that people don't have a need for mental health Monday through Friday, 8 to 5. And so the investment in the communities has not occurred. When you see the 28-year-old with schizophrenia who, when they're on their meds, think that they're not ill, so they stop taking their meds, and they're in Tallahassee, they're hallucinating, they're hearing voices, they start screaming, and then what happens? Then the police get called. And they start all over again with the cycle of interaction. You know, many county sheriffs will tell you they are by default the community mental health system, which is a travesty. And the same is true, of course, with our emergency departments. They become the revolving door because individuals cannot get access timely. Medicaid is the dominant payer in behavioral health. I tell every legislator, new, returning candidate, ask for a tour of Chattahoochee. This is not meant to be disparaging, by the way, of any state psychiatric institution. It is, unfortunately, however, a reflection of how much we've got to do to improve the quality of care in behavioral health, in mental health, and the investments that need to be made in the community. I started with Jessica at the clubhouse. The clubhouse, here we go. It's very inexpensive. The clubhouse is inexpensive. Assertive community treatment teams, 24/7 in the community, a little more expensive, still far less than somebody in an inpatient psychiatric unit. So mental health in this state, in this country, still very fragmented, crisis-oriented, siloed, and not driving the modernization, the evidence-based approach to diagnosing and treating for the best possible outcomes. We've got a lot to do. I will say, because we've done such great work reducing the stigma around mental illness and people are talking about it and asking for help, the legislature has really increased some of the funding for substance use disorder and mental health here in Florida. We've just got a lot of ground to make up. And again, we've got to measure what matters and make sure that the care, the treatment is improving the lives of so many that depend on the system. I'm going to conclude there. So in case we have some questions, happy to respond. Thank you all very much.
Thank you so much. That was a lot of extremely eye-opening and I hope actionable information. Thank you so much. I'm going to bring up Dr. George Rust, who is a professor here and the co-director of the Center for Medicine and Public Health and Policy. To moderate.
Thank you very much. Well, thank you all for being here as well, and thank you for entertaining questions. And I told you ahead of time we would probably ask you for a free consult. Imagine, though, that world where financial incentives are aligned to get people the right care in the right setting at the right time to get the best possible whole person outcome, above the neck, below the neck, whole person outcomes. So imagine that we lived and worked in that kind of a system. We have the ability to build FSU Health, an academic health system, for that brave new world, right? Because we're building it from scratch, essentially. What would that look like? How would you do it? How would you help us with our partners move away from thinking about how much am I getting paid for this hospital admission, for filling these hospital beds, for doing these expensive procedures, and move toward how do we all, community, hospital, primary care, how do we all work together to get everybody in that red part of Florida, that bad health outcome part of Florida, to the best possible health outcomes?
So I am going to talk about that, but I think it's important to understand the disconnect, because again, before I was in this role, I was overseeing the state's Medicaid program and in another state overseeing the Medicaid program for over 6.5 years. So for me here in Florida, the question was, so we've privatized, why the misalignment? We all know that people shouldn't be in the emergency department if it's non-emergent. Do we have enough primary care physicians to treat them? We all know that children need timely access to dental care. Florida has the worst track record in the country practically for access to dental care. So I said, when I was secretary to the actuarial firm, no, wait a minute, we've put measures in the contracts with these private insurance companies, with Centene, with Humana. What happens when they don't produce on those contract terms? And the response I got back from the actuarial firm, well, the federal government requires that you pay actuarially sound rates to these insurance companies, so you got to pay them. I said, well, where's their skin in the game? So there are entities making money, okay? There are entities making money off the system. If you are making money, that is not generally an incentive to change what you're doing, okay? So we've got to acknowledge that. And it is difficult to unscramble the egg, even though what I said is true at the beginning. We can make this complicated, but fundamentally what we should be seeing and expecting from the system is not complicated, right? Right time, right care, right setting, best possible outcomes. All I can say is I'm a big believer in risk-based contracting and value-based payment arrangements. 20-something years ago, Medicare started accountable care organizations. Good accountable care organizations produce amazing results because they are looking at the full continuum of care. It is about population health. It is about not only the inpatient admission, when they're discharged, did they get into their primary care physician's office? Did they get to see the specialist? Do they have the home health that they need? Here's the problem. If you don't employ all aspects of that continuum of care, I have struggled with how do you make all the payments work? Because, again, you've got two public payers, Medicare and Medicaid, that dominate, Medicare even more so. Medicare is the 800-pound gorilla in every state that dictates how care is paid for, and that informs the landscape. And everybody has a different approach, from a doctor's office to a home health, in terms of how they're paid. Somehow, we've got to really take a look again at the accountable care organizations. The concept is the right concept. Continuity of care, reduce fragmented, if you've had to go to a specialist and you arrive at the specialist's office and you say, do you have my record? And they go, no, the primary care physician's office didn't get the record to me. So that is we're still using the fax machine in healthcare, right? If that's not an indicator of some of the antiquated, but I think value-based, pay for outcomes, risk-based contracting is where we've really got to focus our energy.
Very good, thank you. We'll take some questions from the audience. We've got a few minutes, actually 2 minutes. Anyone? We have microphones, yes, sir.
Yes, hi. Thank you for the excellent talk. But what I'm curious in terms of your thoughts for whether it will be worth looking at a nationalized healthcare, given that the private healthcare sector model seems to be unsustainable for the foreseeable future.
The problem is it's those two national entities, Medicare and Medicaid, that are driving the misalignment. So they privatized, and the example I would use, if you had somebody coming in to renovate your kitchen, and you just said, gosh, I hope you do a good job, I'm gonna come back in 6 months, and I hope it's what I want. When Medicare was privatized, Congress restricted any oversight by the Centers for Medicare and Medicaid Services. So during the pandemic, when I was setting up COVID isolation facilities for individuals that needed nursing home level of care, I find out that the Medicare Advantage plans are not contracting with the COVID isolation facilities. It's an emergency, it's a crisis. I called my friend at Medicare and he said, we have little to no authority over these health insurance plans that are now doing Medicare Advantage. In Florida, 55% of all Medicare enrollees are in Medicare Advantage plans. In Southeast Florida, in Miami, Broward, 75% of all Medicare. So I don't move in that direction because that is government. Medicaid is so influenced by the politics of the legislature around accountability. Can we just please make these plans accountable? You can't put names of physicians up on your website and believe that that somehow justifies network adequacy. If I have an insurance card that's Medicaid, but the door isn't opened to me, if I can't get into a primary care physician's office, then we have not met the objectives. And those are two government programs that have privatized that still are not fulfilling those objectives. So I don't go just to single payer or national because I worry about still, especially when it comes to the state level, it's a crisis-oriented budget. Every year, even while the state was flush with cash, for the last few years, until the last 1 or 2, they were putting $500 million in reimbursement rate cuts on the table to hospitals, even though cash was pouring into the coffers. That's what worries me. Because I go in and say, you gotta look at care coordination. We didn't privatize Medicaid because the state couldn't pay claims. Every state has invested billions of dollars in Medicaid claims payment systems. What we said was, we've got 20% of the Medicaid population that account for 80% of the spending. They need a lot of resources wrapped around them. That's why we brought these private insurance companies in. But if you don't create the accountability, we're not going to get those outcomes.
Thank you so much, and we have used up our time. Thank you so much for being here. Perhaps Ms. Mayhew would be willing to stay and talk with 1 or 2 of you afterwards if you have a burning question. In the meantime, we have lunch outside in the atrium, and there may be an opportunity to gather and continue the conversations out there. Thank you all for being with us today, and let's thank Ms. Mayhew.
Thank you.